All right, Assistant County Manager Steele.
Thank you, Chair, Commissioners. Today we have Rachel with Classic Behavioral, Rachel with the CPCCO and Shira with Classic Behavioral Healthcare. And Rachel's here. As you all may have heard, there have been some recent changes with Care Oregon's network policy. And so Rachel is going to provide an update on what those policy changes are and some of the rationale behind those changes. And then Shira and myself are also available should there be any additional questions. And so I'm going to turn it over to Rachel. Thank you.
Thanks, Monica. Thanks, everyone. Nice to see you. I'm going to share my screen. Can you all see that? No, great. I'm not super familiar with. There we go. Hoping you can see it now.
Yes, we can.
Yay! Thank you. I'm really happy to be here today. Thanks for inviting me. I am going to walk through some of our recent policy changes. I will have time at the end for questions. There's a lot of moving pieces though, so I just want to acknowledge that up front. To start off with, I do have to share this slide. The contents of this presentation are confidential. Sharing this presentation is not permitted without the express written consent of Care Oregon or its affiliates. So now we can get to the main event. So this slide is just kind of to set the stage and to acknowledge that I think we probably all are acutely aware that we've been living in a lot of uncertainty in the Medicaid space, and there will be more to come, which has put us in a position to need to adapt, and sometimes quickly. With restricted resources in an ever-changing healthcare landscape, we are all asked really to do more with less. And at Care Oregon and Columbia Pacific CCO, our mission is to make sure that we remain positioned to support our Medicaid members who have the most needs. That's why our behavioral health strategy is rooted in ensuring our members, especially those living with the most complexity, receive not only consistent and accountable care, but also care that is connected to our broader health system. It really does take a team. This slide goes over kind of a high-level timeline of multiple initiatives Care Oregon and CPCCO have had, most of which are in the past. The two I'm going to spend the most time talking about today are the Board Registered Associate Policy, which went into effect August 1st. So we're just over a month into that policy change. And then our contracted outpatient policy change, which will be effective October 1st. So that one is right around the corner. You will see on this slide the June 2026 date, which is just a call out that Care Oregon will implement the final OHA Board Registered Associate change. I just want to be really clear that the policy changes that Care Oregon and CPCCO have engaged in are separate from OHA. We have separate processes from OHA. And I know it can get confusing, especially when we're talking about the same provider type. So just wanted to point that out on this slide. So let's get into it. The board registered policy. So what changed for Columbia Pacific CCO? Effective August 1st, the following provider types, which you can see listed below, are no longer eligible for reimbursement for routine outpatient mental health and substance use disorder services when billing as an individual provider or under a non-contracted or non-certificate of approval group. And with this change, Care Oregon is really aligning with industry standards. Nowhere in the country outside of Oregon, actually, are individual unlicensed mental health providers allowed to bill Medicaid or commercial insurance, for that matter, directly. They need to be working under another organization. And beyond that, we really believe that our contracted providers, especially those that hold a COA, help ensure equitable access to care for our members, especially, again, those with the most needs, because they really have the ability to provide a full service array, and are experts at connecting and coordinating care with the broader health system. These providers also work very closely, or at times are providing the full continuum of services, including crisis services. These providers are fully supported in upholding our standards in safety, clinical care, credentialing, and oversight, and are best able to serve our members. Again, especially in a time of restricted resources. So I went over the kind of big timeline, and now I'm going to get a bit more into the weeds about the timeline and communications for this policy change specifically. So this takes us way back to December 2024, feels like a lifetime ago, but that's when we first notified all of the impacted associates that this change was coming. We really strive to get ahead of these changes to support the impacted providers, but also to support the impacted members to ensure that they can get connected to care with providers who will be able to continue to get reimbursement. In February of 2025, we hosted a listening session for impacted associates to get feedback. And that was all before notifying our members. We realized the impacted associates started notifying members they were supporting and connecting them to care elsewhere before then, but that's when our official notification went out. And then August 1st, the policy went into effect. Again, you can see the June 2026 date, which is next summer, is when OHA's potential rule change may occur. We'll be tracking that, and if OHA does make an official rule change, then we will align with their rule change as well. This is just a bit about OHA's timeline, which again is separate from ours. They also have had community engagement sessions, continue to have opportunities to provide feedback, which is all part of their required process when engaging in the rulemaking process. So we're right now kind of in between the blue and orange, where they were starting to draft the rules, get feedback, and then by the end of this year are expected to finalize a rule change. We're keeping an eye on this timeline because it could change at any point, but we believe they are still tracking to this. If they do have a rule change at the end of this year, it would go into effect in summer of next year. Okay, moving on to our policy change for requiring moving really to a contracted outpatient behavioral health network. So I realize there's a lot of words on the slide. I apologize, but there are a lot of moving pieces, so I want to make the information available. Care Oregon and Columbia Pacific are implementing a policy change to require outpatient mental health and SUD services be received by contracted providers. So again, this is just for routine outpatient mental health and SUD, and then you can see a list of excluded services below. Again, this change really does align Care Oregon policies with standard managed care practices, requiring contracted provider networks. And it really focuses our investments on providers best positioned to serve our members with complex needs. I'm sure I'm starting to sound like a broken record, but this is really important to us. So those are our providers who have a tier 2 designation, which is OHA language to say providers and organizations whose revenue is 50% or more Medicaid dollars. So these providers and organizations have really dedicated their resources to serving the Medicaid population. And again, a call out here, often those organizations also have team-based care, which allows kind of that full spectrum of services. This change really reinforces our commitment to network quality and accountability through a credentialing process, which is something we obviously can't do with non-contracted providers. We have various supports. Medicaid is super complex, as I'm sure you all know, and billing for Medicaid is just as complex. And so we are dedicated to supporting our provider network in learning best practices and helping to provide tools and things through our program called Medicaid Essentials, which you'll see on here. We also have a value-based program, our quality improvement incentive program that we offer technical support around as well. Again, coming back to that quality piece. You can see the provider types who are going to be impacted by this. And then on the far right, you can see some dates. Like the last section, I'm going to go over a timeline. And I'll walk through all of it, but really want to focus first on this July 2025 date on the far left. I'm going to provide a bit more detail about what exactly that means. So we are very dedicated to ensuring that our members have access to care. This is going to be an ongoing focus of ours. And in July, we did go through a process, which I believe is a piece that is often missed in our timeline, of reaching out, of doing an assessment really of our current network, contracted and non-contracted, and really needing to understand where exactly are our members seeking and receiving care, and wanting to be proactive about reaching out to providers that we don't currently have a contract with who meet different criteria, which are listed on the right. So we reached out and offered contracts to providers who were seeing different member volume thresholds. And I also want to call out here that Care Oregon, obviously, or maybe not obviously, we serve 3 different regions: the Portland Metro, Jackson Care Connect down in Southern Oregon, and then the North Coast in our region, all of which have very different population makeups, volumes of members. And we couldn't just do kind of a blank number of members served in all 3 regions. So this was customized to each region, and within our region, even customized to the needs of each county. So in some instances, for some of these categories, we offered contracts to providers who had seen at least 2 members, serving at least 2 members in a language other than English in the past year. So in some cases, our thresholds were incredibly low to try and mitigate any risk of there being an undue burden on our members because they're living in a rural region. So we're currently going through the process through kind of what we're calling this proactive contracting, reaching out to these provider types, encouraging them to walk through the process with us, supporting them through that. We also have standing kind of panel status to try and fill gaps or prevent gaps in our provider network. Those include contracting with providers who meet OHA's CLSS, which stands for Culturally and Linguistically Specific Services. So if we have a licensed provider who goes through that process with OHA and requests a contract with Columbia Pacific, we would contract with them for outpatient mental health or SUD services. So I just want to call out that piece, that a lot of care was given to that to ensure ongoing access and reduce member impact to this change. And ongoing, which is kind of that bottom highlighted part, is that process isn't ending October 1st. When this policy goes into effect, we are engaging in a continual assessment of our members' needs, our network needs, and filling gaps where we can. Let's see, I'm gonna kind of zoom back out to the full timeline. So that process that I just spoke about happened in July, just a couple months ago, feels like, again, a lifetime ago. August 1st, we sent out the first notifications to impacted providers in various cohorts. In mid-August, we wanted to notify members to ensure they had time to connect with other services. We also engaged in contracted network coordination and conversations, engaging not only some of our anchor providers like our CMHPs, but also some of our other contracted behavioral health providers. And we also engaged in quite a bit of care coordination and direct outreach to high-risk members to ensure that they would be connected and could get connected to ongoing care. September 1st, so just a bit ago, we sent out another notification to providers. And then at the end of this month, we'll be sending out a third to both members and providers. And then again, you can see that October 1st date is when this policy change will go live. This slide speaks a bit to our organizational assessment of impact, and I'm going to get into a bit more detail about a couple of these points. The top two showing that this policy change impacts about 19% of our outpatient behavioral health providers, but only 6% of our outpatient utilization. The next slide will go into more details, including Clatsop County specifically. But kind of the main takeaway here and what we've seen through doing our own internal assessment is that we have a lot of providers serving a small number of members. Many of these providers impacted are telehealth providers who are not located in any of our counties, who are seeing maybe one member or two members, which makes it really difficult for us to engage them in that larger system of care conversation, help support them in ensuring those members are connected to all the services available to them. We have also seen a very large cost differential between our contracted and non-contracted provider groups. I know there have been a lot of numbers floated around in the media, and some of them are true. At times we see up to episodes of care, cost per episode of care for our non-contracted providers can be 50% more expensive, which often comes back to our inability to monitor utilization and ensure medical necessity for services. It also means that we don't credential these providers, coming back to the quality piece, and we are unable to offer that kind of best practices for billing Medicaid, engaging with them in a more robust way. At a point in time, these numbers are changing all of the time, but as of a week or two ago, this was going to impact about 500 members across our three counties, Clatsop, Tillamook, and Columbia. And we did an equity assessment and saw that a higher proportion of adult white English-speaking members are impacted than our overall membership, compared to our overall membership. And I have more details on that as well. Okay, so this comes back to a bit more detail about again, kind of the number of providers and how many members they're serving, or what percentage of members they're serving. I know there's a lot of numbers on here. I'll focus on the Clatsop County. So what this slide is showing is not that there are 187 unique mental health or SUD providers in Clatsop County, but there are 187 unique providers who are serving members who live in Clatsop County. So again, coming back to these often telehealth providers who are seeing maybe one member a year, maybe two members a year. So really aren't connected to the robust supplemental care, primary care, CBOs. They aren't part of the larger network in Clatsop County or in any of our counties. And they represent care for 8% of the outpatient services to members in Clatsop County. And you can see kind of the specific breakdown of adults and youth impacted. The next slide shows the detail of member impacts by language and race. Again, we're seeing our members who speak English disproportionately impacted by our initiative, our contracted policy change, and then our white members as well. Thanks for hanging in. We're almost done with the slides. I know it's a lot. This is kind of a summary slide just to say that a huge part of our effort has been engaging with our key partners, our currently contracted partners, and those that we are offering proactively a contract to, because they are engaged in our system of care. They are serving a large number of our members already. We've been partnering very closely with our tier 2 contracted providers. And again, those, especially with team-based care, we have been monitoring member access and will continue to monitor member access and then actively close gaps as we find them, which is the third point. I got ahead of myself. We are putting processes in place to assess for and fill gaps in our current network. And that's it. Any questions?
Thank you very much, Rachel. I saw all kinds of hands go up, and then I have a question myself, but we'll start with Commissioner Wakua.
Okay. Am I still sharing my screen? Sorry. Again, not familiar with. I am. Okay.
It is, yes.
Thank you, Chair. And thank you for the presentation, Rachel. I was kind of just curious. Obviously, looking at the statistics, I understand the language data. What impact does race have to do with this? I'm just curious. Why were you cross-referencing that information?
Yeah, we were cross-referencing that to ensure that our members, our BIPOC members, weren't disproportionately impacted. So one place that we actually did see that was with our American Indian and Alaska Native members. We did see that there was about, with this, sorry, I could have kept the slides up, but it'd probably take more time than necessary. 8% of our members there are impacted by this change. And overall, they represent 2% of our total population. And so what that signaled for us was that we needed to actively look and pursue contracts for that services and providers who are culturally specific to kind of close that gap, which we did do. So that's why we're looking at that data.
Understood. Thank you. Appreciate it.
Yeah.
Thank you, Commissioner Wakua. Commissioner Thompson?
I think Commissioner Webb was first. I'll go after her, if you don't mind.
Okay, Commissioner Webb.
Thank you. This is a real very complete presentation to the extent that I understand what's going on. There was a statement in the materials that we were given prior to the presentation you made this morning. It's on our page 5 of our packet, and it's talking about our commitment to equity, access, and accountability. There are 3 points under it. And one of them is, this cohort has shown significantly higher levels of utilization, and we have also seen a higher rate of fraud, waste, and abuse in this segment. Could you expand on that? Who is that referring to?
I'm guessing, Monica, is that from the talking points document for the
Yes,
change?
it is. It's from the ones that were sent out. Yeah.
Yeah. So that is in reference to the non-contracted provider group. In doing review, some of these folks, when notified, requested contracts, which we would expect. And that process allows us to review past claims, notes, things like that. And that's where our teams were able to see kind of some themes of that. Medicaid fraud, waste, and abuse were higher within our non-contracted providers than in our contracted provider group.
I
Does that
see.
answer the question?
Could there, I'm confused. I didn't know there were non-contract providers.
Yeah.
Is that, I guess I've always assumed that, that in order to, Medicaid itself has so many rules about,
Yes.
well, just so many rules. And so, so this statement talks about providers, not uh, about, not about recipients.
Exactly.
Okay.
Yeah.
Okay.
Yeah.
Okay, thank you. The other issue, I guess, also on the previous page, you talk about, and it's under the heading of what this change is not, which actually I felt it was kind of interesting the way you divided that up. This is what the change is, and this is what it's not. And
Mhm.
one of those issues says not eliminating the single case agreement process when medically necessary. What does that mean?
Yes, welcome to the world of Medicaid. So,
Yeah.
yeah. So when there are providers, and these tend to be providers who offer higher levels of care that we don't necessarily have standalone contracts with. So an example I could use would be like a residential eating disorder program. Let's say that we had a member in need of that level of care and didn't have a direct contract with them, or this provider is really needing higher rates than our standard rates, we can go through a negotiation process with them and establish a single case agreement, which is also kind of like a short-term contract. We enter into a short-term contract with them for one member to ensure that our members have access to the full spectrum of care as deemed medically necessary.
Okay. Interesting. I didn't know that was ever the case.
Yeah, and
So,
just to reiterate, single case agreements will still exist and do still exist after this policy change.
oh, okay. Okay. Thank you. Thank you.
Yeah, thanks.
Thank you, Commissioner Webb. Commissioner Thompson?
Thank you, Mr. Chair. Well, I appreciate hearing your presentation. The level of detail and the complexity is very impressive. I want to speak as your ally and have questions.
Great.
So, we're aligned in wanting to provide services efficiently and effectively, so I want to support that. I did notice that there was a high percentage, I thought, of people who didn't report race. And I wonder if that impacted, because as I looked at the numbers of racially reported clients, I thought, well, not a lot of difference, some, not a lot, 2 to 4%, but the percentage was 3 times that of folks who didn't report. So I just noticed that.
Mm-hmm.
The second thing is, this is my meat. This is where I came from, was being a caseworker. I was licensed as a clinician in Michigan, went to Alaska, did administrative work, gave up my licensure, came to Oregon, and found that the process in Oregon to be licensed as a clinician was so difficult and expensive and time consuming that I did other things.
Sure.
I wonder if you as an organization, and I've raised this issue at LGAC, I've also suggested because of the shortage of qualified providers, that they consider reaching out to people who have been or could be licensed as providers, because they're talking about having providers work part-time and otherwise accommodating the workforce. So to the extent that your organization can impact licensure and workforce issues, I would urge your support of that. I'd also note my persistent complaint is that there's no Clatsop County Commissioner on your board, just saying, okay. The third thing is, having been just lately the delegate from this board to the HSEC, there's some local heartburn that the HSEC wanted to voice. And I think it, again, is part of being constructive allies to you.
Thank you, Commissioner Thompson. I wanted to turn it over to Shira, but I wanted to kind of add to your point, Commissioner Thompson, because you really touched on what my comment was as well. Is I know I've had conversations with owners of private counseling services here in Clatsop County, Shoreline Counseling being one of them, and I know they are very concerned about the process, about how long it will take to get folks a COA. And of course, this also adds an administrative burden onto them for compliance. And there's a lot of things that go into this. And so in a time when we're trying to get as many counselors and providers available for the need in our community, which is a growing need, I think we really need to help a lot of these existing providers along to get those folks their certificates and in compliance. And I hope that there's some direct, communication with services like Shoreline Counseling. I know that they filled out a survey, but I don't know what beyond that has been done. But I certainly want to bring these folks along and get them in compliance and do whatever we can to make sure that it's an efficient and a smooth process. Okay, Shira?
I don't know if Rachel, you wanted to respond at all to Commissioner President? Sorry,
Yeah,
Rachel.
I appreciate the concern. It's always helpful to hear directly from our communities. And I guess what I can say is that what wasn't included in some of these timelines that I shared today was Care Oregon and CPC-CO working very closely with not only OHA, but also the governor's office to make sure that they were aware of these changes that were happening. And I feel like a big role as a member of the CCO is, of course, advocating on the behalf of our communities when it comes to things like administrative burden, many of the things that you all have mentioned. And those efforts are absolutely still in play. And unfortunately, the processes that you are outlining around getting a COA are things that our OHA owns. And so our ability to impact that, or the licensing boards, ends at advocacy, which we have been doing, continue to do, and really see as a vital part of our role as the CCO. But just want to clarify that piece in roles.
Yeah, thank you, Rachel. My understanding that it's a time-consuming process and that it's very laborious, and so yeah, that's something that OHA I hope can streamline. Shira.
Thank you. As a COA, I can confirm that it is laborious and time-consuming, and that there are really important components of that from a quality and control perspective. And I really wanted to speak also to what Commissioner Thompson was kind of asking of Care Oregon regarding the complexities around licensure in Oregon. I was asked to participate in the Governor's Talent Council Committee, which focuses on workforce retention, recruitment, pipeline development. So I get to work closely with the First Lady and other executives across the state in really tackling this issue. And while this isn't a Care Oregon owned problem, it's a licensing board owned problem. So there's the LCSW board and the LPC board, and they really set their own regulations and expectations around what the licensure process is. But this group that I'm working with is doing a lot of advocacy and pulling in members from those licensing boards to have conversations about reducing burden and complexity and streamlining process, because I completely agree. I think it's really important that that component of this work be addressed. Whether you're working for a CMHP or a COA, or you're in private practice, I think licensure needs to be streamlined and more accessible. Thank you.
Thank you, Shira. Commissioner Thompson?
Well, thank you. I was a health licensing board executive director, and the members of the board that govern these licensing areas to protect the public, which is a noble endeavor, those members serve at the pleasure of the governor for the most part. So I would think that the governor would have a clear and direct influence on how those boards function, up to and including revision of statutes if it's required. I think I just did a sermon, sorry.
No, that was good. Thank you, Commissioner Thompson. Do we have any other questions or comments? Commissioner Webb?
Thank you. Thank you, Chair Quayla. I wonder if, I guess this is a question for both Shira and Rachel. I have a similar tale to Commissioner Thompson's. I have a daughter who has a master's in social work, who works in one of the best school districts in the country, Fairfax County, Virginia, and has, when she first started having her babies in Northern Virginia, said to me, "Mom, I can't imagine raising my children anywhere but in Oregon." And she's been trying for 6 years to get a job in Oregon. And it's the damned licensing issues that always get in the way, as well as the fact that she makes about twice as much money in Virginia, which values education and human services, as she would in Oregon. And it seems to me that we've got some very, very existential issues with our delivery system and the way we monitor and license it in the state of Oregon. It's a personal issue for me. I don't like being 3,000 miles away from my grandchildren. But we have one of my responsibilities on this commission is to be liaison with the workforce development infrastructure. And this is very, very upsetting to me. I hear from providers that they have trouble hiring people because A, the process is so difficult, and B, people don't especially want to come to rural Oregon because of the simply non-competitive pay. And to me, these are systemic issues that somebody in this state ought to be working on. And today has just made me even I have to use the word angry that somehow we're not doing enough to make this system operate more effectively. Can you, either of you, make any suggestions on what those of us who sit on local county commissions do? What can you just suggest? What can we do to make this system better?
I mean, I think you, if you don't mind, Chair Quilla, if I respond.
Yes.
I think you hit the nail on the head there, Commissioner Webb. I think that pay inequities in this sector of healthcare are our primary reason for struggling with workforce. The amount of education that's required to deliver this level of care compared to other sectors of healthcare and other industries. And then, you know, when you look at equitable pay, it's really, really low. I don't know what they're paying in Virginia. I do know that I participate in national conversations about this pay problem, and it is a national issue and it is a systemic problem. I think the more that we talk about valuing behavioral health and education and paying people appropriately on any platform that you have, is what we need to continue doing. And this is also a primary topic on the Governor's Talent Council, and really focusing on issues related to pay. Of course, Oregon's not in a great place when it looks at our revenue forecast currently, but we know that we need to pay behavioral health providers more as they spend, the better part of 7 years in education, and then add 2 to 3 of additional supervised years pursuing licensure. It's pretty significant. I also have one semi-unrelated comment, but I want to make sure that if other commissioners are speaking in response to Commissioner Webb, that can happen first.
Go ahead, Shira.
I think that I've kind of heard just through some things that came up in HSAC, and unfortunately I missed the last meeting, so I wasn't able to be there and be a part of that conversation. But that there's maybe some impression that my organization, CBH, as the Community Mental Health Program, benefits financially from this policy change that OHA and Care Oregon are moving forward with, and that's not the case. So I just want to make sure that everybody's really has a good understanding of how our finances work and how we're funded. So CBH, as the Community Mental Health Program, we're actually paid on a capitation basis from Care Oregon. So we get a certain amount of dollars to serve our community, and that's fixed, that's set. So unlike folks in private practice who bill for a service and then get paid for that service, that's not how it works for us. We have a set amount of money that we work with, and then we render services to the community. So if we bring in more clients and we're rendering services to those clients, it does not change how much money we're getting from Care Oregon. So I just wanted to be really clear about that. Thank you.
Thank you, Shira. Appreciate your clarification. I just one programming note here. We're going to actually postpone the discussion on Fort Point and put that to a meeting coming up. So Terry, sorry about that, but we'll go ahead and reschedule you to our next meeting, and we will still have the FEMA BIOP discussion on the EIS from Gail Henriksen, our Community Development Director. So I know that we have some hard outs here today, and so we're going to have a short meeting. I just wanted to see if we can just go right to the FEMA BIOP after we complete this discussion. Okay. All right, Commissioner Thompson.
Thank you, sir. Quick question. I had a concern raised to me about the accuracy of the data provided by Care Oregon. I'd like to know if there's a way for community members, particularly HSAC members, to get a fuller picture of those data and feel comfortable that they are true and accurate data. And you don't have to answer that question, but please take it into account and please reach back to the HSAC. Thank you.
Okay, thank you, Commissioner Thompson. Commissioner Wakua.
Yeah, thanks, Chair. Not really a question, just more kind of an open dialogue conversation. Obviously, 2 of us on this board are involved in healthcare. We understand the constraints that the rural setting provides as far as bringing in talent, assistants, quality providers, things of that sort. We see it on a daily basis. The rural area is tough. We saw recently Providence Seaside lose a department. They've been trying to recruit a provider there for 2 years and unable to get a provider. Obviously, I'm not talking about mental health here, but just across the board. We had a discussion yesterday with the state and some upper ups, and basically there was some data that was discussed, which suggests that providers pretty much, when you talk about a population of less than 20,000 or so, providers have less than 10% of available providers have interest in going to work for a population of that size. When you get under a population of 10,000, it almost dwindles to 0%. For the effort that goes into these educations, it's not about money. It's just about the volume of work they're doing afterwards to see people and justify what they put into their career and whatnot. We're fortunate when we find people with skill sets that want to be here, and sometimes we have to force that with recruiting and pay. But we have a struggle here on the coast, and it's across the spectrum of care. And it's just something to be aware about. It's not I don't have a solution for it. Unfortunately, it's something that we just have to realize, and everybody deals with it in this realm of the world. So that's all. Thank you.
Well, thank you, Commissioner Wakua. A lot of good sermons here today. I can't disagree at all with what has been said, and I really appreciate Rachel, you being here to present on behalf of the CPCCO and let us know what's going on. And Shira, thank you for carrying our concerns to your work group and to the governor's office. I agree that that's where those changes have to come, and we'll continue this dialogue and discussion. And certainly, if there's anything that either of you need from us, just let us know. But appreciate the participation in this, and thanks again for all you're doing.
Thank you so much.
Thank you.